1, 2, 3, prova.
Okay, welcome everyone. This is a great opportunity to be together with all my friends, people that I don't know, and I'm here with Dr. Picozzi Andrea,
Hello everybody.
and we're live from Italy to talk about prolotherapy, and this is an opportunity. It's a trial, it's a demonstration to see if this can be part of education in the near future. We're doing this, it's going to be an hour of my time to communicate with all of you people out there. We have many prototherapists online that's watching us, and I think that things are going to be okay. And right now, I really want to say a few words to say this is definitely something very important for all of us, because we're going to be trying to communicate with simple understandings. I'm sorry about that. Okay, maybe nobody heard me. Okay, there was a demonstration error. Okay, welcome everybody again. Sorry about that. I'm Dr. Stephen Cavallino, and I'm here with Andrea Picozzi.
Hello everybody.
Yeah, this is a demonstration for prolotherapy, the international group here in Europe. I'm the director of Prolotherapy School, and it's an opportunity for us to see if this is going to be some type of way of teaching, getting a demonstration. We're doing the streaming demonstration to see what is going to be the feedback of this. And today our outline is going to be, we're going to talk about a little bit about the knee and the shoulder, two pathologies in prolotherapy with Andrea. And to take into consideration, I just came back from Mexico in an international mission. I came back yesterday, and it was a great opportunity to be with many different prolotherapists at various different levels to understand, that things are growing. We can share together new techniques and understand how effective prolotherapy can be once we start sharing amongst ourselves. And I really want to thank the man that taught me most of my prolotherapy that's not here with us today is Jeff Patterson. I do have many mentors that I do want to thank for what I've learned so far, especially Carl Osborne, who's going to be with me in Greece in this coming summer, because we want to make this an opportunity for many prolotherapists and many therapists to be able to heal people. I'm going to define what is actually prolotherapy for the people that don't understand, because we have a lot of people online that are watching that don't know what prolotherapy is all. So, prolotherapy is an injection therapy to improve our healing and to regenerate damaged tissue. Our body is made of different connective tissues, which are ligaments, the joints, and tendons, which come from muscles. And our body has a fantastic way to heal, but we heal incorrectly many times because we take anti-inflammatory drugs and we listen to doctors that tell us that you must rest, put ice, and so on. Ever since I learned prolotherapy, my whole understanding about healing has a whole different aspect, a whole different new understanding. And to the prolotherapists that are out there listening, we all agree to the same. But people that don't understand, well, I have pain. Well, where is the pain coming from? What is the cause of the pain? Well, pain is caused by some type of instability. And our body is made up of various structures that are so important. And the most important structures of our body that holds the bones together are our ligaments. And if these ligaments become weak, and they do become weak, because with age they become weak, then they start to ask help. And who's going to help these ligaments to compensate the joints? That's the muscles. Now these muscles and tendons are overworking. And so we need to address and understand we need to treat these ligaments that are laxic, tighten up the area so the joints function well and the muscles will work less. What do you think about this, Andrea?
I totally agree, and of course, this can be a comprehensive course on prolotherapy. This is especially a test to see if this can be a useful platform for educational purposes, but definitely prolotherapy is a very special therapy to treat the connective tissues, so endopathology, what we see every day with our patient in our pain clinic, in our sports medicine activity, and definitely impairment of the connective tissues helps to cure a lot of conditions, like as you mentioned, instability,
Sure.
hypermobility, and a lot of tendinopathies, including tendinopathies with partial tears. So a very wide condition of conditions.
Okay, well, thank you, Andrea. Again, the biomechanics of our body change when the ligaments are weak, the muscles are working too hard, and then we always say it's a posture issue. Yes, it is a posture issue, but what is the posture issue all about? It's probably because we need to understand the ligament laxicity. So many doctors don't realize, and this is not, I'm not here to criticize, I'm just here to inform, that our body needs to have an opportunity to heal better. So with prolotherapy, all we're doing is we're taking a simple needle with some dextrose at different percentages, and we are injecting into the ligaments or the tendons or the joints to regenerate. Now, the prolotherapy is using a solution. We use dextrose, and dextrose, it has various different properties, and the most important property is it regenerates. It has a regeneration stimulator for growth factors, and that this is for the public. And you're asked to, by the way, Andrea is a physiatrist. Perspective. Let me see if I can tighten up the ligaments. For example, if I take the knee like this and I show you the lateral side of the knee, which is the lateral collateral ligament that Andrea, if you can try to focus on this ligament when you can, the lateral collateral ligament in the medial side, the medial collateral ligaments of the knee are extremely important. And we have two other ligaments are in between. They're inside the knee, which is the cruciate ligaments, which you have the anterior and the posterior. These four ligaments are actually what makes the knee function correctly, the joint function correctly. But with age, the joints become weak because these ligaments don't change their size. They stay where they are. It's just that the joint starts to reduce because the cartilage is being consumed. So now you have ligament laxicity. These ligaments become too weak. So if they become too weak, we inject these ligaments on where it's inserted through the skin with some anesthesia, and we try to what I call a screwdriver effect. The injection solution will cause an inflammation, and this will regenerate the tissue. The connective tissue starts to repair. So what we're doing is we're saving these patients to go to other types of therapy that could be probably sometimes not good for them. Now, surgery is the last option. We try to cure the knee instability by treating it with prolotherapy, but the whole body can be treated with prolotherapy. Today we're going to talk about also the shoulder. We don't have time to go through many different issues of our cases because this is just a trial to see if this is a way that we can continue to have lessons maybe once a month, talk about one specific area. We can bring in clinical cases. So I think what I'd like to do is just go quickly through the knee and make it understood that the knee can be treated with just prolotherapy solution. And I just want to underline one thing. Prolotherapy is an injection therapy using a solution. Now, there are doctors out there that are using PRP, stem cells. That's a solution. And they're putting that into the joint or on the ligaments. That's prolotherapy. Prolotherapy means proliferating therapy. And that's part of regeneration medicine. So I hope you all understand at least the basics of what I'm explaining. Andrea, so what I want you to do for me is if you can focus on
Yes.
the medial collateral ligament. The medial collateral ligament of the knee, if you can see this on my model here, it's a big, broad, about 10 centimeter ligament. This is big, and it's injointed to a big capsule. And it blends in with the medial meniscus, because that's part of the capsule. If we treat this medial side of the knee, now most of the patients that come to us, all these sports injuries, a lot of people, even the old people, the elderly people, have a lot of medial side knee pain. So the medial side knee pain needs to be treated. And so what we could do is we could treat the medial collateral ligament, we could treat the coronary ligaments, which is the ones that are holding the meniscus into place. We can treat the muscles that are coming down, attaching on the tibia, which are the three major muscles, the sartorius, the gracilis, and the semitendinosus muscles. That forms your pes anserinus. And that's covering the medial side of the knee. But again, they might have medial side pain, and we're not looking at their patella. Where is their patella located? Could it be too high up? Does it need to be reinforced? So we also do reinforcing around the patella and try to reach many different ligaments of the patella. Like, for example, you have the patellar tibial ligament that is on the inferior border of the patella, attaching to the medial side of your just above the pes anserinus. That ligament usually is not usually not infiltrated or not injected. But when we're doing the pes anserinus, we're doing it high up, or we're doing this area, and you're injecting this, you're definitely getting a better result for your patella. I'm going to move to the lateral side of the knee. In the lateral side of the knee is not in a capsule like the medial side of the knee. You have your lateral collateral ligament, which is attached from your femur to the fibular head. And this structure here is very easy to treat. We just do, it's not a deep injection. We go to the femur attachment, to the peroneal head attachment. And we can also treat the coronary ligaments of the meniscus to make sure that the meniscus does not move. So if we tighten all these ligaments up, what's going to be our outcome? This patient's going to have less pain, and the muscles are going to work less. And so what we can do is, and of course in this patient we're going to give a joint, and we're going to put an intra-articular injection right into the joint. Now we can do various approaches. We could go under the patella. We could do the intra-articular from the medial approach or the lateral approach. That we discuss in our lessons when we give our lectures. Let me just go to the last, when we'll go through the anterior cruciate and the posterior cruciate. Okay, the anterior cruciate is a very important ligament that holds the knee from anterior to posterior. These ligaments are attached internally to the femur condyle, okay, and they're attached distally to your tibia. The posterior is posterior, and anterior attaches to the intercondyle space anterior. These can be approached in different ways. So if we have the patient with their knee flexed at 90 degrees and we use the medial approach, we try to go into the intercondyle notch. As you can see, I'm going right in here. And what I advise the most of you prolotherapists is try to avoid to go too deep. Because if you're going to go too deep and you're going to fall onto the meniscus attachments, you're going to be causing a lot of pain to these patients. And these structures are hypovascular, and they're going to be, that meniscus that's blending in with the ACL is the one that sometimes is really the major cause of their pain there. So what I'm saying is, if you could stay a little bit more to the tibia side, and for personal results, you're going to still do well. Your proximal attachment is further back, and your injection is going to be parallel to the floor, going a little bit from the medial to the lateral side, getting to the medial to the lateral lateral surface of your femur condyle, where the attachment of the ACL is, as you can see that, okay? When we do the PCL, which is a more complicated injection, you're going to have your patient in a prone position, and you're going to have them with their foot off the table. Positioning is extremely important, palpation and drawing. I didn't underline the drawing aspect, but because we don't have time to do that, but I advise all prolotherapists to draw your anatomy. I don't care. I was taught to do that, and my drawing memory is what makes me, until today, get better results. Of course, we see a lot of prolotherapists that are injecting without drawings. I believe that even if I have excellent accuracy and so on, that you need to draw on your patient. So when we're doing the posterior cruciate, we're going to have the patient prone, we're going to do our drawings correctly, and we're going to make our injections. I'm not going to go through the technique here because it's more complicated, okay? So I think I covered pretty much the knee. The point that I really want to get across is, let's take the large number of patients that have knee pain, and these are the people that are over 50. The majority of these patients can benefit from prolotherapy because these injection therapies are not painful, very easy. They get a treatment once every 2 to 3 weeks, 3 to 4 treatments, and they should be pain-free. Now, if they're not pain-free, how degenerated are they? This is if we're talking about degenerative disease like arthritis, how advanced arthritis are they? If they're in their 3rd, 4th grade degeneration, they're up for prosthesis, you have to be fair. You can probably make them make it through the next year, but their problem is they need a prosthesis because there's no more cartilage left. So what do you think about this, Andrea? Do you have any quotes to make on the knee? And of course, all you people out there probably have some questions, but people that don't know about prolotherapy, and believe me, this is a therapy that's all over the world. In the United States, in Canada, Australia, Italy, Europe, we're trying to promote this, and this is one of the reasons why we're here today. So I hope this message gets across, and to all my friends, of course. We're going to be going to Honduras next month, and Honduras is another mission. We go at our own expense to teach at the Hackett Hemwall Patterson Foundation, which is, I call, the Harvard School of Prolotherapy.
Definitely, Stephen. And concerning the knee, well, you know, in our everyday practice, we see a lot of people who are addressed to us with knee pain, but already have been going through maybe some hyaluronic acid injection or some other treatment. And what I think it's a very big issue with prolotherapy is that it takes in a big consideration, you know, not only the intra-articular damage of the knee, but of course addresses the treatment effectively to all these structures you mentioned. And most of the time, you know, you get a lot of people who just get better even without needing very big intra-articular treatments, you know, and sometimes the pain generators of the knee are actually mostly extra-articular, you know, and you can see this clinically, sometimes also with imaging and ultrasound. And
you're correct. You know, we in Mexico, we saw over 1,000 patients in 5 days. And it was incredible how many patients were knee patients. I think we saw about over 600 patients of those, or 700 patients were just knees. So that's just to show you, we can help these people. And you know, there's an article that just came out in the UCLA article that's saying that knee pain is related also to overweight people. That's not the issue, and the article explains it well. It's not being overweight. Of course, you have to fix their weight problem, but it's the whole structural issue. The bias and tensegrity has changed, and if we can tighten up their ligaments, and I've treated a lot of these people, and I'm surprised that they respond very well. I'm really surprised because I says I got to fix their weight problem, but it's not only the weight issue. It's their ligaments are not functioning. Can you imagine someone being so much overweight? And if they're so much overweight, they must be tearing up those ligaments really hard. So what do you think about that one?
Absolutely, absolutely. And not only with OA cases, you know, we see also a lot of, for example, ACL repairs, surgical repairs in a young population of patients. And what is my clinical, experience is definitely that most of the time, maybe the anterior posterior stability is restored by the surgery, but then again, most of the time they have together with that, you get some impairment of a collateral ligament that hasn't been fixed properly, even with the healing response after the injury. And you get so much improvement in the rehab phase, treating those structures, that the surgeon didn't repair during the surgery, that it's impressive how much gain you can get by treating together with the surgery of the ACL, also the lateral and the medial and lateral collateral ligaments.
I want to add something that Andrea is saying. I agree with you. Since Andrea is a physiatrists do physical therapy, they do the correct change in posture, you fix your pace. We have to realize that our body has a fantastic way to heal, but we also have to realize that if we're unstable, if a joint is unstable and you have pain, where is this pain coming from? Like I said before, it could be the ligament elasticity, but it's your muscles and your tendons that are overfiring and they're working incorrectly, and then you become chronically pain in different areas. So if you have knee pain, doesn't mean that it's coming directly from your knee. It could be also that you have your hip that's not functioning well, and that means you're not walking correctly. Your feet have to be looked at. So a prolotherapist become very good clinicians, and I think that I want to share this with you. When a patient comes in my office, they come in with all their medical issues, their charts, their x-rays, and they just throw it at me. And in the beginning, I used to do all that looking, wasting time, is what I call. Not anymore. I said to the patient, let's talk about your problem. Why are you here? Tell me. I want to make a clinical diagnosis. And my patients become surprised. How? You didn't even look at my x-rays. I says, I don't need to look at your x-rays. I will look at your x-rays at the end of the visit. I'll get on the bed. So what I want to share with you is we all become good clinicians. Differential diagnosis. We're going to go through that today with the shoulder. Differential diagnosis is extremely important. If you start to do prolotherapy, you just start injecting where they have their pain, and you don't understand where the pain is coming from, then I think you need a little bit of brushing up to do. Pain doesn't necessarily have to be that area. It could be referred pain. Like in low back prolotherapy, Hackett-Hemwell's book does talk about referred pain. This referred pain is in the low back. You could have your iliolumbar ligament, you could have your anterior groin pain. Where's that coming from? It's your iliolumbar ligament. But if you don't treat that ligament, that anterior hip pain is not going to go away, and then you start treating the hip. So I believe that a good prolotherapist needs to understand, can I make a clinical diagnosis, and can I really, really study my patient from A to Z? You, Andrea, should probably give more emphasis to this because you're a physiatrist. So what is your understanding?
Well, my understanding is that ligament is a very important pain generator that most of the time is not addressed properly by clinical examination because of what you were telling before. Most of the time now we are trained to look a lot at MRIs and scans and X-rays, so even doing those very simple and quick tests that you can do in your office to the patient looking for instability and the palpation of the ligaments can really give you useful information and address the treatment to those structures that are so important, together with of course everything else that we've been doing already and that we're able to diagnose. But definitely, instability, especially not evident instability, is something that we need to really look for. Sometimes comparing the contralateral side, the healthy side of the injury, and getting a feeling of how the proprioception of that joint is altered, also with some functional tests, especially in athletes. Reproducing the movement that they feel is impaired now after the injury, and that really then addresses you to look for the connective structures that need to be treated with this therapy.
Again, many times we become addicted to the smile. I think all of us prolotherapists that are watching, we are all addicted to the smile, and that means we know that when a patient's going to come in our office, if they're smiling, they are part of that 90% healing. I believe that prolotherapy has this fantastic effect. And this was born more than 60 years ago. It was invented years ago through Hackett Hemwall, and they're the ones that brought the Hackett Hemwall Patterson Foundation to understand it there. So this is not something new. It's new for Europe. It's new for many different countries. So that's why we're here for today, the trial. We want to see if there's going to be feedback from the public, from doctors that don't know what prolotherapy is. And this is something that can develop in the future. This is our personal gift to you all, and all our mentors and all the people that have helped us become who we are today. So I guess we can start talking a little bit about the shoulder. And since Andrea is the fellow doctor that works with me when we give these international courses, and he does the shoulder. And I really like his work. I really like his results. So I've given him the opportunity to lecture with us. And we're a group, and we're a growing group. And I think that the shoulder is a very complicated area. It's one of the pathologies, frequent pathologies after the knee and the back. The shoulder, I think, is about 30% of our patients.
Definitely.
And shoulder problems, you'll see more of that in the United States, probably because of baseball, and because of that's a big frequent sport. But for example, in Europe, you'll see a lot of issues that could be the groin issues because it's soccer and lower extremities. So upper extremities, the shoulder has many ligaments, and again, the ligaments are what keeps the structure together. If there's a weak ligament, that humerus is going to start floating up and down into that glenoid, and it's not going to be working well. And if it's not functioning well, then the muscles are going to overfire, and then you're going to get what I call a possible frozen shoulder. Then you're going to say, well, it's due to the supraspinatus, which is one of the rotacuff muscles. But it's the supraspinatus that's secondary to what's happening. So if you have a ligamental, and when I always ask the patient, how is your pain? You got to get some clinical evidence. I have night pain. Night pain for me means it's ligamental because the muscles are not working at night. It's your ligaments that are trying to hold the bones together. So Andrea, so you could talk a little bit about the shoulder. And
yes, well, we have a little shoulder model.
Yeah.
Here,
I'll hold the microphone for you. Okay, and you could discuss this. How's that?
So yeah, in our courses, of course, now this is a setting in which we don't have a model, so we won't be doing the drawing. But
this
of
is
course,
only a demonstration.
It's just a demo, just to get a feeling from who's online watching at us. If by showing you the the anatomy on the screen, on the back front, and by addressing the anatomy in this way, you can still get a feeling of which is the approach we have. Well, we don't have the time to go through the physical examination, which is something which is actually pretty crucial to address properly the treatment, because of course we must understand if we are treating the tendons, the ligaments, most of the time both of these structures, and we need to understand, if the shoulder has mainly a tendinous problem, or a problem due to a luxation, a subluxation that has damaged the ligaments. So, of course, all the tests for instability and the tests for the tendons must be addressed very, very specifically. And
simple tests.
Simple tests, but done with a very precise order and taking your time,
Mm-hmm. Well, yeah, I could add something to you, very simple testing, and we can't do that here, but just the range of motion. Automatically, the range of motion, when a patient does the range of motion coming up and down, going back and forth, and they say that they have pain going up and down, or their range of motion equals pain equals intra-articular injection of prolotherapy. It's a safe solution. It works. So they bought themselves an injection right there. So just that one simple exam is already telling me they're getting an intra-articular injection. That's my view. Then we're going to do testing for the rotator cuff muscles. And we do these 3 or 4 different tests. And then I think another very important test, which I call is the O'Brien test, the false and positive. You're testing the AC joint, and you're testing also the supraglenoid, the superior glenoid ligament, the glenohumeral ligament, and it's what we call the slap lesion. Many of the orthopedic surgeons want to operate on that. Well, if it's not a 3rd degree, or it's a 1st, 2nd degree, then we can offer the patient a possible cure. And you, Andrea, have treated many patients with these lesions, I as well. And I've seen that, shoulder in the beginning for all the new prototherapists is difficult, and sometimes you're expecting.
Yeah, shoulder definitely is one of the challenging joints to be treated with prolotherapy, but also prolotherapy really gives you a chance to...
You want me to hold this, and you can hold the microphone? That could probably be better.
To save a lot of patients to an aggressive surgical approach that sometimes is offered to the patients as the only solution,
Right.
Let's remember that especially when we've got a partial tear, most of the time, of course, we have evidence with ultrasound and with MRI of a tear, But then from the clinical examination, sometimes patient has still a very good range of motion, and in a prolotherapy experience, we know that if we treat the tendon only, we will get only a partial result. Most of the time when we start treating the tendon and the tendon gets some healing, also let's remember that it depends on which part of the tendon has been damaged, because not every layer of, for example, the supraspinatus, we can have some very important tears of the supraspinatal and still have
show on the diagram
full range of motion,
right, wow,
whereas we can have some very small tears that give a very big impairment.
So Andrea is going to try to localize the supraspinatus attached with the most frequent rotator cuff injury is a supraspinatus. And this muscle is extremely important. This tendon is extremely important for the shoulder. Now, if this muscle is completely detached, then the other 3 rotator cuff muscles are going to overwork.
Absolutely. And most of the time, you need to give some treatment also, to the infraspinatus, which of course starts, there is an overlying of...
He's using the computer.
There is an overlying, you see, especially in this area, sometimes it's very hard to say where the supraspinatus is ending and where the infraspinatus is beginning. Okay. There is an overlaying, as you can see, of the fibers in this area, and many times, even with important tears, of supraspinatus, infraspinatus will still, deliver part of movement, and you get patients that are really functional. Especially, we know that surgery after, a certain age doesn't give very good outcome in elderly patients. So sometimes just even treating, the part of the tendon which is healthy, still healthy and attached to the adhesives, and making it stronger doesn't make the tear develop in a full thickness tear, or doesn't make the tear, involve also the infraspinatus. And this gives the patient, together with rehab, some very good outcome. And of course, we all know that supraspinatus tendinopathy and spondylitis is really something we see very, very frequently in our office. And this has changed my practice, definitely.
Well, what do you think about, if you do have, on this model here that we can see this model, the supraspinatus, we all know, is attaching to the greater tuberosity of the coming underneath coming from the supraspinatus notch, coming all the way to the greater tuberosity. What's happening here is if this muscle or this tendon is damaged, what happens actually to the biofunctional biodynamics of this humerus head? He starts to go a little higher up instead of going further down and staying into his proper position. There's a smaller change, and that's what's causing us to get into a more degenerative disease, an advanced degenerative disease. So proper treatment, you know, and many surgeons that I've seen, Andrea, in supraspinatus surgeries, I'm pretty surprised at the carelessness that these patients are coming to me saying, I don't feel any relief. I mean, they had the surgery. They're worse. 30% of the patients that go through surgery, I think that's the statistics.
Well, you can talk for yourself. You were almost deciding for.
Yeah. Well, let's share this with everybody out there. You know, that's a
your
good
story is a real story. So.
Well, okay. Let me just go quickly through it. I think my story is a good story. As many of you know me, I'm a football player. I'm a football ex-pro football, American football player in Italy. Played for the Italian professional team, and you know I never got tired of playing football. Then I went into flag football, and that's where all my injuries started. I'm 56 years old, and I still play. So last year, I injured myself again after 3 years ago breaking both my shoulders, my AC joints completely torn up. And so last year I fell on my shoulder diving in for a touchdown. And I was so happy I scored the touchdown, but I yelled, and I knew something really damaged. And I actually could not move. My shoulder was worse than ever. And to make a conclusion, I tore my my supraspinatus tendon was completely torn. But I wasn't convinced, so I had to go. I developed a frozen shoulder, and I finally decided after 3 months or 2 months, I think I went for an MRI to see if it was torn because I didn't believe it. I says, oh, this is just a contusion, and the frozen shoulder is probably a defense mechanism. You know, your body defends against any more injury, so it like blocks. Well, I went for an MRI, and it was pretty painful because the orthopedic surgeon said to me, you're going to get an MRI he injected me with dye. What do you call the contrast? Sorry about that. And because he thought that there was a slap lesion, he thought there were other issues, he thought that the ligaments were broken, the glenohumeral ligament, so on. Well, the long run, it came out that I had an I had a supraspinatus complete tear. And so my next step was, now what do I do? I'm a prolotherapist. God, I know if you have a torn ligament, a torn tendon, I'm not going to treat that. I can't get anywhere. And this was last year. And I went to the orthopedic surgeon. I spoke to my orthopedic surgeon's friends that I'm teaching prolotherapy in Naples. And everyone I spoke to that said, you need surgery. And Dr. Susan Lanza, who works with me, she said, Stephen, don't go to surgery. Let's go to Mexico. So last year in January, go to Mexico and be treated. So Andrea treated me before we went for Mexico, and that was my first treatment. Then in Mexico, I got many injections, a lot of injections, but I can tolerate it. And the improvement was outstanding, outstanding. After 2 months, my range of motion has improved. I was doing physical therapy. Today, I played this year football. I could move. I could not lift my arm, and I could not sleep. So I did ultrasound before and after. Now ultrasound, what does it prove? My supraspinatus was not completely torn. Remember that the MRI is a static photo of that area. It's not mobile. Remember, ultrasound, you can move. So the photo it said that it was completely torn. What do you say, Andrea?
Absolutely. Yeah. I remember doing an ultrasound on your shoulder, and I was pretty worried when I first saw the images. But again, yours was one of those cases in which ultrasound could actually outline a little bit better than MRI, you know, because of the edema, probably the MRI was a little bit overestimated. And you had, in a certain area of the supraspinatus, especially the most anterior part, the cable portion of
Right, which was this area
the
here.
cable portion
Right.
of the supraspinatus, the anterior cable portion of the supraspinatus, and partly the crescent portion was definitely torn, but then there was a part of the fibers that was still attached.
Posterior fibers that we could not see, and
And
definitely.
we actually treated, the healthy fibers together with, putting some, just some normal prolotherapy with the dextrose in
And we did
in the
all the
bursa
ligaments.
and
We did every
yeah.
ligament of the shoulder.
And then, of course, addressing also all of the, superior, anterior, and inferior,
right. The whole
and
posterior
posterior
capsule,
glenohumeral
anterior
ligaments.
capsule.
So it was a very overall treatments, but in the end, we were all astonished by the result. Of course, he was developing a frozen shoulder, so he had to do some very intense physical therapy together with the prolotherapy treatment. Prolotherapy is, it's not a one, a standing alone therapy. It must be integrated with physical therapy, with rehab, also with other techniques you can combine. But of course, I mean, when I saw the results on Steven, I was pretty impressed too. And really, all the surgeons we talked to, they were all on the same line. They were aligned for surgery because in the beginning, myself too, I was, pretty sure it would have been ending up going for surgery. So prolotherapy really gives you a tool, especially in those patients that, for example, are on a waiting list for surgery and they're in pain. It has happened to me many times that, they have 6 months to go for a shoulder surgery with the national health system here because of long queues,
Right,
but,
you have long waiting lists, yeah.
long waiting lists before. And these patients are in pain, and meanwhile, you want them to arrive to surgery in the best conditions, So you tell them, look, let's, keep on with the rehab so that you don't get a muscle impairment, in this period, and you arrive to surgery with a good, muscle balance. And sometimes what happens is that you do the physical therapy and you treat the tendons, with prolotherapy, and they just improve dramatically.
The surgeon said to me, by the way, one of the best surgeons for the shoulder in Italy, said to me, he says, I'm not operating on you until that frozen shoulder gets better. So he put me into rehab. And that's probably where I saved myself. Yes, I listened to Dr. Lanza, but I saved myself because it was time. So I had time to realize that I'm going to fix my shoulder with rehab, and then eventually, but the prolotherapy actually did the job. So this is to share with you, and I'm sure you guys have a lot of cases out there that are similar or want to share with us. Again, this is a demonstration YouTube trial streaming live for all of you. Hopefully we can do this more often. I need good feedback from you, and our European school needs to understand if there's a possibility to grow. And as we're going to Honduras, we got a lot of work to do there as well. Hoping we'll have time to come back to work because we leave our jobs to do all this therapy to help the poor people. And this is a way to say thank you for what we have. What else can we talk about since we have some more time? We want to...
Maybe sometimes for questions and get some feedback from our friends. Cause,
all right, we have a Skype phone number I put up on there, and when I was saying about differential diagnosis of the shoulder, I just want to bring one issue across with patient comes in and says they have anterior shoulder pain, okay? And their range of motion is painful, so they get themselves an intra-articular injection. And they have all the other tests for the rotacuff are negative. Just the supraspinatus has a small. Then I double test that supraspinatus with a Joba test. But that's fine. Now I go in and I do an O'Brien test, which is AC joint. This is the slap lesion, which is the superior glenohumeral ligament attachment. And they're both positive. Oh, that hurts. Oh, this one hurts. Well, what do I do now? What is actually the cause? Is it AC joint, or is it the joint itself below, the glenohumeral joint? So what I do is I give an injection right into the AC joint. What? Lidocaine. put that to sleep. I retest the patient after 5 minutes. This is negative, but this is negative. So that means the slap lesion is not there. That means he's not getting that injection. So I'm saving myself to go into the glenoid, the labrum area, putting in an injection for what? Because he has a positive test. No, the positive test is the AC joint. That's the cause. And if we start to treat the area correctly, patient's going to love you. And matter of fact, that the superior glenohumeral ligament is affected when they have night pain. They are also, the posterior inferior glenohumeral ligament is also affected when they have night pain. You've got to get a good clinical understanding of the shoulder. Also important is, how did you injure yourself? You know, oh, when I was playing, or when I was pushing, or I was pulled by my dog. There are so many issues that can help you get the understanding. I have a case that was pretty difficult that came to me. This woman at around 40 years old comes to my office in Naples and says to me, I can't deal with my low back pain. And I visit her, and she does have facet pain. She has L5-S1 pain. And her hip was also painful, but I wasn't convinced where I was supposed to inject her. Why? Because her story told me that there was something else. She was walking and but walked into a hole and pulled her whole right side hip and iliolumbar ligament just went completely out. So I treated her iliolumbar ligament, her S1, L5-S1 joint, and her ABCD, which is her sacroiliac joints and ligaments. She came back after one treatment, said, what did you do? I'm better. She was, I think it was about a year and a half, going everywhere, all over Europe, seen by the best specialist, a very wealthy person. She sent me so many different patients, and when she came to me for a second or third treatment, she started to emotionally cry, say, you saved me. So there are many cases that we all have similar, but this case was, and I'm going to conclude with this was understanding the dynamics of the trauma. The trauma can give you so much information, but if you're too fast and you don't want to realize, well, I'm going to treat what they're saying they have. No, understand why. Mm-hmm. We got 15 more minutes to go, and I think we can go. Okay, so you have those ligaments on there. Can we show that? Let's just show you the iliolumbar ligament is a big structure, right? That's attaching from the L5 and L4 transverse process to the anterior portion of the ilium. And if we look at it, it's a big, broad ligament. This is an anterior view that you're seeing. And the posterior view, it's not that easy to get to, but when we do get to it, you're going to help your patient a lot. And you know, another case, Andrea, that I think is important, the iliolumbar ligament, is also in the spondylolisthesis, which is the sliding of two vertebrates, especially L4 and L5. If you treat the iliolumbar ligament, is the only way that you can help, and you treat your supraspinous ligaments, which are these here, I think you can get some type of improvement. Low back pain, 70% of low back pain is coming from everything below L5. And that means all the ligamental structures, the SI joints, that's the area, this whole area, turn it around, this area right here is the area where most of the, show them where all the action is. And if you realize, if you look at that, there's so many different structures that are held together by these ligaments. And don't get fooled by the posterior aspect of the pelvis. You got to also look at the anterior aspect of the pelvis, which is your symphysis pubis, and then those muscles in the front are working, overfiring as well. So I think that we have a lot of work to do to understand when we're looking at low back pain. And remember this issue. I believe 70%. I spoke to some doctors that believe 80%, even 85% of low back pain is not due to disc disease. Even if they have these discs that are pushing out, it's not that. Do we have anything that's coming through with Skype? If there are any telephone calls, we'll take them. Let's see from our section out there, is if there are any phone calls coming through, that'll be fine. If not, we can just continue talking here because we're not going to be doing any more demonstration. What do you think, Andrea? I think we got about, whatever, 5 more minutes left or 10 minutes to go? Okay. And so let's talk about Honduras. What is your experience in Honduras, Andrea? You know, since we got time, we'll wait for some phone calls. If the phone calls don't come in, it's not a problem. This is a trial. We got a Skype phone number for you, so we don't know if anyone's going to really call us or not. Okay?
Well, Honduras is life-changing. Every doctor who approaches prolotherapy in a basic course, eventually, when he knows the basics, he should definitely, you know, get onto one of his missions. You know, Honduras with HHF, or Mexico, or hopefully very soon in our European mission, because really the chance you have to get a one, you know, educational program in which you have an instructor following you during the whole day in examining the cases,
Teaching
supervising you during the treatment,
palpation skills,
yeah,
teaching
exactly.
you.
Giving you those little you know, details in that really make your technique in palpation, examination, and injection technique improve day by day is a standard of education you hardly get in any course, at least here in Italy.
Well,
you know,
we're going to be going.
So
We're going to be going to Greece.
it's a great chance for, I hope, for example, to involve a lot of young specialists, you know, who are really enthusiastic to approach prolotherapy, because I know how much I got from Hacketemel Foundation and the Honduras missions, and I'm proud to say that most of the skill I earned is thanks to these missions, you know,
Definitely.
out there.
Definitely.
And
I always said
and now I'm really happy to have a chance to, you know, to give something in return and help
Yeah.
the
I
foundation
always said
teach
this.
some new doctors around the world. So
I agree with you 100%. You know, the fact that we take time from our work and we dedicate weeks to these missions for free. It's because we want to say thank you. This was probably the best training I ever received in my whole medical career. I'm an emergency medical physician. I do emergency medicine. And when I learned hands-on adjusting how to palpate, to work side by side with an instructor, and now today I am one of the senior instructors, and becoming the director of the European mission in the future means that this is never going to finish for me. I love to teach this. I love to share it with others. You know, one doctor one day said to me, "Why are you doing this?" This is an Italian doctor. "Why are you getting involved in teaching others? You're going to be losing, you're going to be selling, they're going to steal your patients." I said, "That's not the issue for me. I don't care. I know that I have the tools and the ability to help people. That's why I became a doctor." And all the doctors that went through the HHPF Foundation are the ones that really have the ability and the heart to be happy, help others, and have fun. And you know, Carl Osborne, who's for me is my best friend, one of my best friends, is one of the best, I think the best prototherapists we have in the whole world, has shared with us and will be with us in Greece this year. We're going to have a European mission to teach the European doctors, and some American doctors are joining us, and we're going to have also some other instructors. Marty Gallagher and Annette is going to be coming, and Mary Doherty is going to be coming as well. So it's going to be another opportunity to teach prolotherapy all over the world. You, Andrea, went to India. You have also experience in India. I went to Sweden. We've been to Greece. I've been to Austria. It's just a fantastic way to teach, to learn medicine, and be happy.
So how many minutes to go? Okay, we still have Do we have any questions?
Mm.
Let's see.
Alrighty. There are some questions that are coming across. Okay, but, well,
So somebody is asking how much does it take to get trained in prolotherapy?
well, the train.
Which is the learning
You know,
curve?
I always remember. You know, Lisa Smigel is a very good colleague of mine, and we started pretty much together many years ago. I've been doing prolotherapy for more than 13 years now, and Lisa said to me, "It's going to take you about 5 years to get your practice going." Meaning, you have to get proper training. It takes you. You got to go through the best courses. You got to go to Honduras, Mexico, Europe. You need the clinical training with an instructor. And 5 years, I'd say, was the time where I really realized that I can close my emergency medical practice and move on myself. And Lisa always said to me, says, "You're going to be the godfather of Italy for prolotherapy." And today I am full-time prolotherapy. I have 5 different offices all over. And the reason why I have these offices is to give an opportunity for doctors to take courses to come and work with me side by side. That's the main reason. And so I've been training many different doctors this way, and I'm so happy to do this.
Okay, so 5 years to become an expert.
Well, you become
Kind of,
you,
or very confident.
Yeah,
but after how long do you think a doctor can start actually putting some prolotherapy in his practice?
Okay, well, I'll give you an example. The 2 doctors that I've been training for 2 years now that are in Naples, they are pretty much on their own. They've been doing prolotherapy now for a year. They haven't done a mission yet, but that doesn't mean that they're not able, because I see them every 2 weeks. So they're with me every 2 weeks, and hands-on hands with me. So if you have an opportunity to be part of a doctor to be with you, an expert, then you can learn much quicker. But if you're on your own, you must go to different missions. Look at Susan Lanza, Dr. Lanza. She's been going to all these missions. She's on her own. She can do prolotherapy now anytime in the whole body. There are different areas that you don't feel comfortable doing prolotherapy. Don't do it. Leave it to someone else. I mean, look at the TMJ, like temporomandibular joint. That's not an easy injection. It seems easy, but if you don't know where you're putting your needle, or if you don't have the right angle and you do it and you cause a hemorrhage, then you got a problem. If you cause nerve damage, you got a problem. So sometimes we must say no. I'm not, you know, I remember when I first started, I didn't want to do any cervical spines. I didn't want to do any necks because I thought I was just too afraid. Just, the training was incredible, and it taught me to do everything. And I'm sure that you went through the same thing.
Yeah, I agree. Probably if you have an intense training as the one we are, starting to develop, and with now our teaching, our educational model in Italy is developed in 3 weekends in which we were teaching the basics, and then of course you need to attend at least 1 mission, I guess, to get a little bit more confident before you start doing the easy injections.
Yes.
Then I think you need at least a period, depending on your ability, of course, but let's say that 2 or 3 years before you start covering almost all of the areas of the body. You know, it's average.
There are a lot of doctors that do different therapies. They do acupuncture, they do mesotherapy, a lot of different therapies. If you do all these different therapies and you don't focus on I just do prolotherapy, I see 15 patients a day. Sometimes I see more than that, sometimes I see less, but I see volume. And that's how you become good. If you really, really want to learn this, you really want to help people, this is a fantastic opportunity. The Italian Association of Prolotherapy, the SIPRO, S-I-P-R-O, is online. You can look them up, and that's where we are. That's www.cipro.eu, right? EU, which is, or Prolotherapy. If you look up Prolotherapy in Italy, you will see it'll come up. The fact is that we would love to teach doctors, but we don't want to teach doctors that don't have willing and just a chance to help others. We want to teach, you know, I screen these doctors out. I don't like to have doctors that just want to come, learn, and they take one module instead of taking all three, and I don't see them anymore. And it's been happening like that, and I'm not happy with that. So I need doctors to participate, be with us. And the thing is, I'm not going to go on doing this one-man show all the time. I really need the help from all of you. So this feedback that you people can help us with will do well for all of us. And we're going to form the European Association of Prolotherapy in the near future. We're very close. And we're going to have an international committee. And you're all invited, all you big experts, okay? So we got 1 minute to go, people. And I guess that this is about it. We were really, really happy to share this with you. This is a free opportunity for you people to understand who we are, what we're doing, and maybe we can be together one day together.
And please send us some feedback, because we need to know if this platform, can be a useful tool to do part of our educational program, especially for people who have distance problems, and if it can be a good interactive model, also from people attending these lessons from home and interacting with us during the lecture.
All righty. So see you all in Honduras, Mexico, Europe, wherever. That's for you doctors. And the people out there that need treatment, look up Prolotherapy. I'm sure you'll find somebody in the United States. And remember, the HHPF Foundation is where the best doctors come from. Remember that. I'll never miss it. Thank you, Andrea. It was good to be with you all, guys. All right. Fantastic.